Good morning, everyone. My name is Matt Greco. I'm the events manager at Life University, part of PSS. Thank you for joining us today in our continuing series of presentations on issues related to aging. This morning, we have Dr. Marla Berg-Weger, if I'm pronouncing her name correctly.
You are.
Thank you. She's a professor emeritus at St. Louis University School of Social Work, as well as the executive director of the Gateway Geriatric Education Center and a fellow in the Gerontological Society of America. She is currently the project director of the Geriatric Workforce Enhancement Program located in the School of Medicine Division of Geriatric Medicine. During 27 years at St. Louis University, she has also worked as social work director of field education and university senior associate provost of academic affairs, interim dean, College of Education and Public Service and School for Professional Studies. Her scholarly work focuses on aging, family caregiving, and social work practice. She has authored 4 books and 100 plus book chapters and journal articles. Recent research focuses on family caregiving, cognitive stimulation, therapy, driving, and loneliness and social isolation. So I'm going to hand it over to Dr. And just say, well, you can put questions in the chat and we'll take questions at the end of presentation.
Well, thank you, Matt. And I'm just so appreciative to be invited to share the information about loneliness and social isolation, and also to share with you a great intervention that we've been working on since actually right before COVID. So I'll share my screen here and get started. I want to thank our colleagues in Helsinki, Finland, for creating the intervention that I'm going to share with you, and also my colleague, Dr. Max Sabatsky at St. Louis University, for his partnership. We do this work together. So we are funded through the Health Resources and Services Administration for a grant entitled Geriatric Workforce Enhancement Program grant. And this grant we've had it at the university for better part of 30 years, and it really does allow us to provide education around older adult issues. So let's get started by talking first about some definitions and prevalence of loneliness and social isolation. As you can see here, this quote I think is just so apropos of these issues. It's an epidemic in plain sight. And as I think I go through some of the prevalence information, I think you'll see that. As I mentioned, I wanted to start with definitions. The terms loneliness and social isolation are used interchangeably all the time. They even in the academic literature, sometimes you can see that they're being used synonymously. So think about them as a quantitative and a qualitative. So loneliness is more subjective. It's the disconnect that happens when our expectations for the relationships that we have in our lives are not met. So we expect something out of a relationship, it's not met, and so we feel lonely. We don't feel connected socially. Social isolation, on the other hand, is more of an objective or quantitative kind of assessment. It's the actual number of contacts that you have in a given period of time. So these terms overlap, as you'll hear me talk about in the next few minutes. There's some research to show one causes the other. But I guess at the end of the day, what I want to emphasize is they can both have devastating impacts on the people experiencing them. So what do we know about loneliness? Well, it's skyrocketed, from the beginning of the pandemic on. Lots more interest, awareness, insights about it, lots of research coming out. But I think what is so interesting is that as kind of a research issue, it's been around since the 60s. And our current and also former U.S. Surgeon General Vivek Murthy in 17 called it a global health epidemic. And as you can see here over on the left-hand side of my screen, he actually wrote a book about it and talked about it it's published in 20, and he talked about the fact that it was a global health epidemic, particularly for older adults then. Interestingly, he just came out last month. He's back as Surgeon General again, and he came out with a significant statement saying that this is an issue that we as a nation need to be addressing. And so I feel good that we are on the forefront of that. It's also been called a public health concern, and it is more prevalent among all age groups. And one of the things I think that did come out as a result of us living through the pandemic for the last 3 years that we have is that at some points, most all of us experienced isolation and possibly loneliness as well. So I think that's really raised the awareness about this. Hopefully we don't forget about it as the pandemic subsides. You can see here a study by the insurance company Cigna back in 18 shows really much higher numbers than I suspect most people would think. About half of the 20,000 people that they surveyed said that they had felt lonely, left out, or that relationships were not meaningful for them. Most people, do feel that they have connections, but almost a little over a quarter, in fact, don't. Interestingly, this last bullet point at the bottom is the Gen Zs, who are the young adults in college age now, and heavy social media users tend to be the loneliest and least healthy of all the age groups in our lifespan. So let's talk now about what we know specifically about loneliness in older adults. Numbers are all over the place. It depends sort of on who's asking the question, how it's being asked, but upwards of 60% of older adults in various studies have reported that they experience loneliness, but generally the numbers are down somewhere in a quarter to a third at any given time. Actually, older adults tend to be pretty resilient in terms, and I'll talk about that in a bit as well. We know that, and I'll talk much more about this in a few slides, we know absolutely that chronic loneliness has, as I said, devastating impacts on older adults, to include, as this slide indicates, earlier mortality for those over 65. I mentioned the connection between social isolation and loneliness, and think of it as almost like a chicken and egg. Does loneliness cause isolation, or does isolation cause loneliness? And I think both are possible, quite honestly. Risk factors, and I want you to note this because I'll be talking about this and you'll see some themes. Risk factors for loneliness in older adults does include isolation, having few activities, living alone, and being unmarried or unpartnered. Also, health issues such as frailty can certainly impact that. I just want to leave this slide with the quote down here in the corner. You can feel lonely even if you're surrounded by people. Conversely, you can be alone and not feel lonely. So it's very, very much an individual experience. So interventions need to also be individualized. So what do we know about social isolation in older adults? Well, we know it's linked for an increased risk to cognitive impairment. And I'll again come back to that issue with more specificity. We also know that it can be an early indicator. So again, a chicken and egg kind of situation. Does it cause increased risk, or is it an early indicator of? We know that people who are socially isolated tend to be more stressed. They tend to lack social resources, and they have impaired sleep. So let's look at risk factors again. Being unmarried or unpartnered, being male, and these are just, at risk, putting people at risk. Lower education and lower incomes. And the issue of the male and female is thought to relate to expectations. Females tend to have higher expectations for relationships than do men, but I think so much in our society is changing that may change as well. This last bullet point, I really want to draw your attention to this. Medicare just came out. I updated this number this morning, in fact. Medicare, Medicaid, CMS just came out with a new amount of what they anticipate that being chronically lonely and or social isolation costs Medicare and Medicaid. It's $7 billion a year because people tend to overutilize the healthcare system. Let's look at predictors. Living in a rural community can place one, not to say that if you live in an urban area that you can't also be, but what tends to happen in rural areas is young adults tend to leave as young adults. And so there's not that built-in support system. Having functional status deficits, again, here's the unmarried and unpartnered, being female, as I indicated earlier, again, lower income and education. The one I want to draw your attention to is the stronger than even health and functional status and partner status are depression, living alone, feeling poorly understood by others, and being a member of the LGBTQ plus older adult community. So those are the strongest predictors. Also, as you note from the bubble in the bottom left-hand corner, is that living in residential care does place one at higher risk. They're not isolated, but lonely, potentially. So just a quiz for the group here, and please put your response in the chat box. Matt will wait just a couple of minutes and you can kind of read me the responses. So loneliness is a greater health danger than cancer, cardiac disease, obesity, or substance abuse. So just put your thought about the answer to that in the chat. And Matt, when you've got you're starting to see some responses, please just call them out.
Sure.
In the interest of time, I think I'll move on because the answer is in the next slide. So think about what you thought the answer was and see if you got it correct. So I've mentioned a couple of times that there are significant negative health and mental health and healthcare service implications for experiencing loneliness and social isolation on a chronic level. So let's start over on the left-hand side, physical health. It places chronic loneliness and social isolation, place you at increased risk for cardiovascular, neurologic, and immune disorders. Often, as I alluded to earlier, it co-occurs with older adult geriatric syndrome, such as frailty, which does increase one's risk for mortality, increased risk for type 2 diabetes, twofold in one particular 20-year study. Here's your answer in the circle at the bottom. Loneliness is more dangerous than obesity. And we know what the implications of obesity are. So that just kind of puts this into perspective, I think. From a mental health standpoint, increased risk, not only just risk, but actual implications for depression. I've already talked about impaired cognition. And in fact, here, the study that's just about halfway down that middle column, 40% increased risk for all-cause dementia. So that is significant. And then I talked also about sleep issues as well. And sleep issues can be tied up into, people can become depressed and not functional and not thinking well if they don't have adequate sleep. So it's all very much intertwined together, but dire nonetheless. Healthcare service utilization, people living in the community who are experiencing chronic loneliness or social isolation, when studied, have in a larger number of visits to their primary care provider, hospital stays, and emergency room visits. And probably not surprisingly, can also end up having to relocate to a residential facility. And decreased activity absolutely can increase all of these things along with healthcare costs. So the quote over here is, loneliness acts as a fertilizer for other diseases. So I think you can see that in this slide, looking at, you have this issue and it just really builds on and creates other issues that place you at even greater risk. This graphic is was big and hard to get on the screen. So I've highlighted what the arrow is pointing to. The physical impact of social isolation is equivalent to smoking 15 cigarettes a day. So if you think about this, equivalent to smoking 15 cigarettes a day and more dangerous than obesity, it paints not a rosy picture for those people who do experience chronic loneliness and social isolation. So what have we learned from COVID? I talked about how there's so much more awareness and interest in addressing these issues. But as Tim Carpenter here says, it's bigger than the physician. This is one of those times where it really does take a village to address this. Dr. Murthy's comment here, during my years caring for patients, the most common pathology I saw was not heart disease or diabetes, it was loneliness. So what have we learned and what we are learning? There's new research coming out every day. Well, we've already, we've confirmed that it's a risk factor for dementia. Very large studies have shown that. We also know that during the pandemic, 3 themes emerged by interviewing older adults. What they said was, you struggle was the first theme. You realize how much you've lost. Secondly, and this is where it really shows the resilience that many older adults have, having gone through all the years to get you to being an older adult, adapting to whatever happens, I'll do my best. And then the last one was appreciating and enjoying what you have. So yes, this has been particularly challenging for older adults because of, the vulnerability to getting COVID, but also you can see that there's this real strength there. Loneliness during lockdowns had varying effects on people, from everything to not really changing from what they had been previously in terms of loneliness. But those that were living with significant restrictions, whether self-imposed or otherwise, or both, did report higher levels of loneliness compared to those that weren't living with restrictions, whether they were there or not. And it really didn't matter based on age and gender and employment status, but it was linked to depression and suicidal ideations. And then lastly, one of the things that we did notice is increases around anxiety and also, having to take all of these safety precautions. 70% of people said at some point that they experienced anxiety and depression at a higher rate than before the pandemic. What are we learning from this? Well, we're learning how important social connectedness is. Loneliness overall did increase for older adults because it was a sense of not feeling in control and not being able to do the things that give us pleasure and keep us connected. So we also have learned from the physical health perspective that being disconnected and isolated can lead to mild cognitive impairment within all older adult groups. Persons with dementia, who had dementia coming into the pandemic, interestingly experienced less social decline, but they also experienced more behavioral challenges, more distress, and depression. So yes, and loneliness decreased slightly 2 points for people who were vaccinated, because I think that gave us, that sense of confidence that we can venture out into the world again. Technology exploded mostly in a good way, but I think we also have to recognize that one of the things that the pandemic showed was there's many, many older adults who are not connected. And there's a lot of places in our country that don't have access. So it did make significant differences for people who had access and either knew how or could learn how to use, technology that kept them connected. So thinking about from the professional standpoint, what should we be expecting that our healthcare providers in particular can do to address this issue? Well, I'll come back to this one. They can they can be assessing it. That's the place to start. But they can also be making sure that they're assessing and treating those things that do result in people becoming lonely and or socially isolated. So for instance, addressing and treating pain, sensory impairments, hearing and vision, incontinence, foot, oral health, and eating, malnutrition specifically. So these are things that can actually create or exacerbate older adults' feelings about being lonely and socially isolated. People who can't hear well, for instance, tend to avoid large social gatherings, and as a result may become lonely. Making sure that depression and cognitive deficits are assessed and treated on a regular basis. Having a comprehensive geriatric assessment, which is getting harder and harder to do because there are fewer board certified geriatricians in the US now, shows that, you know, picking up on these things through a comprehensive assessment can ensure by 25% increase that the older adult will be living in their own home 6 months later. Monitoring what people need, asking people what matters and what do you need, what can we help you with, making sure caregivers are part of the equation, and that the communication between the older adult, the providers, and the caregivers are clear and transparent and frequent. And then lastly, you know, engaging in social prescribing. This is a concept that comes from the UK, making sure that community referrals are known to the providers, and that they make regular warm handoff kind of referrals to resources out in the community. Also, we need to understand what the origins of the experiences of loneliness and social isolation. Where is it coming from? Is this something that the person has experienced throughout their lifetime, or is this something that has just had a recent onset? Making sure that communities, not just providers, but communities are addressing this. And I'm excited to say that they are starting slow. We have to recognize that it's difficult for many people, but particularly older adults, to acknowledge that I'm lonely or isolated. There's a stigma that comes with that. That's the perception. Because to admit that I'm experiencing these is possibly an admission that there's something wrong with me, that people don't want to be around me. So I think we've got to be very mindful about that. We also have to be extremely mindful of the fact that even if it's acknowledged, that everyone has a right to self-determination. So I'm going to share with you a wonderful intervention that's available, but that doesn't mean everyone will want to do that. We need more research. We need to figure out, kind of back to my earlier comment about individualizing interventions. We need to, does group intervention work best for this person? Would they do better in a one-on-one kind of intervention? So we need to just know more. We're on a good trajectory now to understand more. Let me talk now about assessment. And as I just said a couple of minutes ago, the most important thing when it comes to loneliness and social isolation is for providers and family members as well, and caregivers, to just ask the questions with, as a comment at the top of the page says, avoiding judgment, and making sure that you're not just making assumptions. Just because someone lives alone, even though we know that's a risk, as I've said, that doesn't mean that the person is lonely just because they have one or more of the risk factors. So there's lots of ways to assess. You can have standardized scales that we're all familiar with, or you can just simply ask single item questions. What I find so interesting is this comment at the bottom, that women are more likely to say that they're feeling lonely if they're just asked directly, whereas males will be much more forthcoming if they are able to respond to a scaled questionnaire or something. There's a lot of ways to get at it, even with standardized measures. You can talk about social support, you can talk about physical health. Because of all of those connections that I've drawn for you, we know that if someone is depressed or anxious, that might be a good springboard to asking them about loneliness. Open-ended questions can certainly be be a very illuminating kind of insight for both maybe the older adult, the caregiver, and the provider as well. This is a list of open-ended questions that I have collected. And if you have some ideas for me, please put them in the chat box and I'll get them at the end. If you have a question that you think would be particularly interesting, I'll let you kind of just peruse this list. But my favorite one that I've collected is third from the bottom. If you have good news or exciting news, who do you call first? And I think that will open up a great conversation, hopefully, because they give you an answer who that person or persons might be, and then you can, really dive a little bit deeper and have a conversation around who do you have contact with, who are your social supports. If this is the person or persons that they list, that's significant. But I think all the others are good as well. This in the ideal world, which most providers would never have time to do all these things. But again, these are just different scales that we recommend, a number of them that were actually created at St. Louis University. But you can see, again, these are examples of coming at it from any number of different directions. But it's important to know what those risk factors are going in. This is a brand new scale that we just created at St. Louis University for this project. It has been psychometrically validated, so we know it works. But you can see here, it's a mnemonic that spells out alone. And it's really intended to be a conversation starter. And really, again, just to get people to engage around this issue. So I want to spend the remainder of my time sharing with you this intervention that I've mentioned, but with the caveat that is consistent with what I've been saying is one size does not fit all. So I think it's inherent in that statement for us to remember that this is a great intervention. It's been shown to be highly effective in reducing loneliness, but it may not be for everyone. So let's kind of ease into this by looking at what can we be doing at the community level. Even with a great intervention, you still have to have people trained. You have to have people who are willing to invest in the intervention and make it part of their organization. And I think that's where we really can benefit from the most work. So at the community level, we need education. And I was telling Matt before we started that I've given this variations of this talk all across the country, and just often to professionals in the audience, as well as family members and older adults who are maybe not in caregiving roles. But it's important that we all realize the impact that experiencing these things has, and that largely, maybe not totally, can be prevented. We need to develop at the community level, the village, if you will, that I alluded to earlier. We need to make sure that, we've got cities, communities, neighborhoods, even organizations who have residential communities addressing this issue from kind of this multi-system perspective. We need to address structural issues. We need to, that do impact loneliness and social isolation. We need to look at crime rates and accessibility within neighborhoods, environmental factors, and how easily can people get connected to services. And we've got some evidence, but we need a lot more. We need to see where people are going for services, and can we make inroads there. And also, never can forget, what is the role that technology could play? We're much more open to that now, having gone through the pandemic. At the individual level, we need to make sure that the interventions are tailored, they're not stigmatizing, that they do improve people's personal resources. And the jury's still out on this one. Do we need different interventions for people experiencing loneliness than those that are just isolated? So stay tuned on that one. We also need to make sure that we're incorporating physical exercise and issues, as well as strategies to address all of the things that I said earlier are connected and interwoven with loneliness. We need to make sure we're connecting and connecting people, and that we're connecting organizations. That's really at the heart of all of this. And then we need to ask the older adult, what do they want? What are they ready for? What are the risks for their physical and mental health? I can't overemphasize the importance of making sure that we're asking people, what can we do for them? So let me shift now and talk about the intervention. And interventions have been around for several decades. They didn't necessarily always get played out in the research literature because they tended to have fairly high dropout rates and weren't able to show effectiveness over time. So effective interventions to address these issues, as I said just on the last slide, need to include physical activity or exercise, cognitively stimulating content, and facilitators who understand about group dynamics and the issues of loneliness and are really there to just empower people. Circle of Friends is, of course, the intervention that I want to share with you. And Kaisu Pakala, as I said on the title slide, is one of the founders of this. And I think her comment is so apropos. It's not the activities or the leader, it's peer support, group dynamics, and cohesion. Circle of Friends was created in Helsinki, Finland, at Helsinki University in the early 2000s. And really the founders were academics and faculty at the university. And so they've written a lot. They've been prolific in their research and their publishing on this intervention. So we have lots and lots of information. And we were in touch with them when we first learned about their program, and they were been very gracious and supportive of our efforts to introduce it here in the US. So the aim of Circle of Friends, it's a group intervention. It has one sole purpose, and that is to alleviate and prevent loneliness. It's a group that meets 12 times over 3 months, so weekly. A group of 8 is about the ideal number, and hopefully the outcome is that people make new friends, new connections. They are not lonely at all, or certainly less lonely, and that they find a group that they can do meaningful, supportive things with. So as I mentioned, lots and lots of evidence, and I'll just kind of go through some of the studies that they've done. They did one study where they did the intervention and then followed up 2 years later. 97% of the people who participated were still living. At that time, they had better subjective health, meaning self-reported health. They had less healthcare costs and hospitalizations. Very small dropout rate. I don't know how many of you have been in groups or led groups, but a 2.5% dropout rate for a group intervention is very good. I'll talk about some of the unique features of this intervention, but one of them is that after the 12 sessions, the group then goes out and sustains on their own and continues to meet without the facilitator. Only about 40% of the groups that they've worked with over the years have done that. And cognition improved. And then a second study looked same kinds of issues. 95% said they were no longer lonely. 45 to 85%, depending on the groups, made new friends. And again, only about 40% continued meeting on their own. So this is strong evidence for why does this intervention work? Well, the part of the reason it works, it has 3 very unique features. One is that every session is one that includes, and I'll talk about this in a minute more, includes some kind of artistic or creative, some kind of exercise or health related issue, and then a reflection component. Second piece is that the ideas, it's not a curriculum based intervention, which many are. The ideas for those 3 topics that I just talked about are to come from the group members themselves. And then the last piece, as I've already alluded to, is that the group goes out and the facilitator works themselves out of a job, basically. So I think those are all things that really are not seen in a typical group kind of intervention. But it certainly it lends itself to making this a very highly effective intervention. One of the things too, this third bullet point down, fourth one down, stimulation creates new neural pathways. So there's evidence to show that just being cognitively stimulated, which this group can certainly do for people, really does lead to the brain working better. And the pictures, by the way, that I'm showing at this part are from our Circle of Friends groups here in the St. Louis area. So back to our researchers in Finland, they did one 10-year study. So they followed up with people who had participated in Circle of Friends 10 years earlier, and they compared the results. 67% of these groups continued to meet, 40%, as I mentioned earlier. 87% reported no longer feeling lonely. That was compared to 95%, as you recall, and 70% reported finding new friends, which was not quite double, but getting up there compared to previous results. So they concluded, I think quite rightly, that the Circle of Friends intervention is an effective long-term option, and that part of the issue around continuing to meet together means that the group might, and the process they use might sort of morph in and evolve into a different looking group, but that's okay. So who's appropriate for Circle of Friends? We've followed pretty much closely, although in Finland, they say 75 years, they have longer lifespans than we do. So someone, the traditional kind of 65 and older, being able to identify that they are experiencing loneliness or social isolation, willing to participate. You obviously want to make sure that box is checked. And if it's telehealth, then having access to a phone or a laptop. As we age, most of us have some kind of sensory impairment or mobility issue, but making sure that, those are not significant enough that people cannot participate. This is not an intervention for people with cognitive impairment or dementia. However, the founders have said that those with mild to moderate can certainly benefit and participate. So I told you about these three components, and I will share a little bit more. Again, they're art and inspiring activities, group exercise or health themed discussions, and then writing and reflection. So you can see here from our slides that, this can take on any number of different possibilities. You can engage in an art or creative activity. You can have someone come in-person groups can certainly go on field trips to art museums, for instance. When we had to pivot, of course, to virtual during the early days of the pandemic, some of our groups went on virtual tours of the Louvre in Paris and other museums. So you're really only limited by the creativity of the group members and the facilitator. Group exercise and health themed discussions can certainly include things you see here. And again, not limited to this at all. It's whatever works. One of our groups got, we brought in a colleague of ours to teach them about breathing. And so that became then something that they launched every group with. And chair yoga has been very popular as well. Therapeutic writing and sharing. The idea is that people write about their feelings about loneliness and social isolation, and then share that with the group members. We've had groups that were not terribly interested in doing a lot of writing, but they were really very open and welcoming of everyone sharing verbally. So when we do the training for this, we make sure to say you have to know your group and listen to what your group is saying. We've had some just really amazing, sharing and reflecting on past traumas in life, and people have found it to be very, very supportive and therapeutic in many ways. We did, as I mentioned, transition to virtual. These are just some of our experiences. As I said, we had people come in by Zoom. We had, we would do things where we would send out materials. One of our partners has this wonderful intervention called Talk and Tea, and she sent tea bags to all of her group members, and they all got exotic teas that they got to share at the same time and chat about. It just really, again, sort of requires one's ability to be creative and think very much outside the box, even though on Zoom you're in boxes. And some of our groups have done these wonderful life books that they then have for themselves and can share with family members. All right, so I want to kind of begin to wrap up here and share some of our resources with you. So again, looking at this across the spectrum of our society, starting at the individual level, we have to make sure that people feel safe to talk about what they're feeling and to be able to say, yes, I am lonely. And, they may be saying that in the context of living in a residential community or with family members. They can still be very lonely with a spouse or family members living in the same house as them. And so we have to make sure that we really are addressing those issues so that people will feel comfortable to reach out. At the family level, we just need to make sure that family members, whether they're in caregiving roles or not, are aware that loneliness and social isolation are issues as one ages, but also that they're seeing that the older adult has something to give and wants to be involved with others and be connected. So we just need to make sure that we're raising awareness as much as we can. Sorry, that actually went backwards. Apologize for that. So at the community level, we need neighbors, housing authorities, care communities, case managers, and all other providers to again be asking the questions and then having something to offer. It's one thing, and that's why a lot of assessments don't get done, is that the providers will say, I don't have anything to offer. Well, there are programs that are available. During the pandemic, I was just so amazed and impressed with all of the creative things that came out of ways to stay connected with people. And then at the societal level, we need policymakers and organizations to address this. In the UK, they actually have a ministry of loneliness with a minister of loneliness, and they've done some very, very creative things there. We run a Circle of Friends program at St. Louis University in our Aging and Memory Clinic. This is just a sample of our recruitment flyer. We actually are recruiting right now for new groups, and our groups now are still virtual, but we're hoping to move them into in-person or possibly hybrid, so people could Zoom in or they could be there in person. We started this program back in 19, as I said. We created a training guide, and it was just updated last month and is here. We are happy to share it. It's on our website. You can email us, or you can put your phone up and scan the QR code that you see here on this slide, and it'll take you to the website where you can download this manual. And this is actually the cover photo is from a Circle of Friends group. And one of the things that they did for their creative project, and it ran through the entirety of the group, as you can probably imagine, was they did a quilt and pillows. So again, there's any number of possibilities. Our Circle of Friends interventions have gotten some recognition. In 21, we were added to the National Resource Center for Engaging Older Adults, called the Engaged Social Engagement Innovations Hub. We are listed there because this is an evidence-based intervention because of all the research that the group in Finland have done. This past year, we were added to the Missouri Department of Health and Senior Services evidence-based program list. And as soon as the national program opens up again for submissions, which we hope to be this year, we will be applying to the National Council on Aging to get nationwide approval. And what this means is that certain organizations like area agencies on aging are then able to seek reimbursement for offering programs that are on these lists. I've got lots of resources here. AARP has done some amazing work. In fact, I don't know who's AARP members out there, but I signed up for a film that is previewing online I'm looking at my calendar, this Friday at 8 o'clock Eastern time. And it's actually a documentary on loneliness. So I'm excited to see what what the new information might be there, but AARP's done a great job with connecting people. And with that, I wanted to finish early so I can take any questions. Here's my information, phone number, email. Our website is aging.slu.edu, and there's my email address. And on the right-hand side of the page here, we are planning, in fact, later today, going to move the planning a little bit forward, hopefully, to do our first, what I hope to be annual Loneliness and Social Isolation Summit. It will be all virtual, October 13th from 8 to 5 Central Time. And we've got to save the date. We don't have the speakers confirmed yet, but we will also be offering as part of that, the afternoon session of the summit will be to provide our Circle of Friends training for those who would like to start their own groups. The training is 4 hours. And there's no certification, there's no prerequisites. I think that it's not a clinical intervention as such. So, I think people from all kinds of walks of life and educational levels are more than appropriate. It's just, do you have the passion and the creativity? So with that, I'm going to stop sharing and see if there are questions or comments. And I know that Lenore is going to be speaking too, so I want to make sure I allow plenty of time for those things. Any questions?
So thank you, Dr. Berg-Weger. That was fascinating and extremely informative, and someone who's a layman, maybe a little overwhelming. So sadly, the chat has not been working, but people, if they can put something in the Q&A and I can read it. We did get several requests for copies of the slide.
I can send those to you afterwards. I'll send them as a PDF.
Okay, and they can reach out to you through your email.
Well, could I send you the slides and then you could send it to everyone who registered? Would that be an option?
That's a possibility.
Okay, or I can, if that's not an option, then I'd be glad to send the slides if you want to email me, and I will. It looks like the chat is working.
So those are all my chats, I think.
Oh, okay. Okay.
All right. So yeah, I did put a couple things in there. So we did have one person, and I can sympathize with it because I felt a little bit myself, just maybe an older adult that was listening, who's a lay person and feeling a little overwhelmed by it. Any thoughts on just, if you're an older person listening to this? And
yes, it is. And not that I or the others who are, proponents of addressing these issues are trying to use scare tactics by any means. But I think, to be honest, I think many people just assume that as one ages, that being isolated and lonely is just part of normal aging. And so I think we have to present, in some respects, the more kind of dire potential impacts so that we can address that and recognize it as part of aging. I mean, we used to think that having dementia or Alzheimer's was part of normal aging. And I think we all now know it's not part of normal aging. So I think that it's important that we understand that if not addressed, that loneliness and social isolation can take a real toll on people. And So I didn't mean to scare anyone. I'm sorry for that, but just to, help us to understand why it's so important to address this. And I take a lot of stock in, the U.S. Surgeon General during both of his times in office, that he's saying we need, as a nation, we need to do something. And I think that sometimes knowing that there can be really negative impacts, that probably prompts others to do something. It is a little overwhelming. So solutions obviously are just addressing it, making sure that we've got healthcare providers and social service providers asking the questions, and then having something to offer. And Circle of Friends is but one kind of intervention that we know works. May not be suited for every organization that works with older adults, but there's lots of others. Just getting people connected is the main thing.
Okay, so PSS does run older adult centers. So a natural question for me is, since we already have existing older adult center, is that something you feel at least in part addresses some of the issues that Circle of Friends?
Absolutely. And one of our local partners here in the St. Louis area actually runs Circle of Friends at senior centers. So their staff goes in, they're not area agency on aging, or, they're not connected in a formal way to the senior centers, but they developed a program, we trained them, and they actually go in and run Circle of Friends groups once a week. So it's even, you remember my early comment, you can be surrounded by people and still be lonely. So this is a way, even in a congregate setting, to be able to have people who are interested in addressing this issue for themselves. So yes, I think senior centers, I think residential communities, assisted living facilities, and skilled care facilities would also be great places to offer Circle of Friends, or something like Circle of Friends. It's not the only.
Very good. I have a comment here. Is there any concern that the groups could turn into group therapy sessions with people who are not qualified to either lead or, offer guidance that way?
One of the things that we make sure to talk about in the intervention training is that this is not therapy, and that if you identify issues, that you need to help the person get the appropriate treatment that they need, whether that is referring them for therapy, or maybe a more comprehensive evaluation of what's going on. Yes, I thank you to whoever raised that question, because we don't want people who are not trained to be doing this. We do have people who are trained who do run these groups, but I think because it's not a clinical intervention per se, that there is a risk of that, and we stress that in the training, that don't try to treat something that is outside your scope.
Okay, very good. Another question is, how do you introduce older adults to new people and new ideas? How do we get them to be interested in joining?
Also a good question. So I think knowing that they're not going to be lectured or talked at is a real strength of this intervention, as I've indicated, and knowing that they get to decide the topics. The group decided they were interested, one of our groups, just all had an interest in music. And we do, before our groups ever start, we do, with each person individually, we do an interview, and we have an interest survey that we have them fill out. So we know like what kind of work they might have done. We know where they grew up. We know what their hobbies are. We know what their interests are. And so we had one group that that wanted to do something around music. And so each one had to kind of identify their favorite music. And the facilitators then during the session, actually, the facilitators of this particular group were two graduate social work students, and they, of course, could pull up music very quickly. And so they play a song, everybody would sing along, they talk about it. Where were you when, you remember hearing this song? And so that's the draw. And at one of our partner sites, it's caught on so much that people want to know how to get into that fun group. So.
Okay, very good. Before we run out of time, I wanted to introduce Lenora Walker. Lenora, if you're still there, she wanted to just say a few things about our circle of care.
Yes, thank you so much. Good afternoon, everyone. I am Lenora Walker, and I'm a care consultant for PSS Kinship Caregivers Program. The program is stationed in our Grand Family Apartment building in the Bronx. The building is owned by PSS and Westside Federation Senior Housing. It is the first building built for only kinship caregivers and their families back in 2005. The Grandparent Family Apartments provides safe and affordable housing with a support system that enables grandparents raising grandchildren to reach their full potential and to gain essential tools for their success. Our kinship caregivers are seniors caring for children who are not biologically their own, but are blood related. So for an example, it can be a grandmother, a grandfather, an aunt and uncle, or a sibling or cousin. The services that we provide to support kinship families are our youth and young adult services. PSS offers an after school and summer program, workshops and support group for children ages 6 to 18 years old. PSS also assists with educational support, college information, and job readiness. The goal of the program is to make a difference in the lives of kinship youth and young adults by providing an enriched guidance and support to inspire them to reach their goals. For our caregivers, PSS provides an on-site kinship program that is professionally staffed and offers a wide variety of services to both residents and kinship caregivers in the community. These services include support group, health and wellness trainings, social activities, one-on-one and family counseling, respite, and supplemental services. All of our services are free of charge. If you or someone you know is interested in our services or interested in living in the Grandparent Family Apartment building, please call us on our toll-free caregivers hotline, which is 866-665-1713, or visit our website at psscaregivers.org. Thank you so much for your time, everyone, and have an awesome day.
Thank you, Lenora.
You're welcome.
And thank you, Dr. Berg-Weger. We've come to the end of our time. I'm sorry we couldn't get to all the questions. We will try to email out a copy of the slides. So hopefully that will answer a lot of questions, give people the opportunity to review the information. And they can always go to the SLU website as well.
Yes,
Right,
thank you. Thank you again for this opportunity. I really appreciate it. And thanks to whoever put the suggestion to add to my list of open-ended questions, typical social interactions in a normal week. Thank you for that. I'll add it.
Okay, was that? Goodbye, everyone. Thank you for attending, and we'll see you next time.
Thank you.